A woman comes to see you complaining of being short of breath. She has a pizza with pepperoni in one hand, a bag of Doritos in the other, and a kielbasa in her mouth. That's a sausage. Spend 4 hours explaining what a kielbasa is. She's got rales to her apices. She's got a respiratory rate of 32. She has a gallop and a murmur at her apex. She has edema up to her areola, JVD up to her ears. And they don't ask you what the diagnostic considerations are because Helen Keller could get this diagnosis. They'll simply ask you what you're going to do first. What would you do first for this patient? What's the best initial step in management? What you do first? X-ray or ABG or digoxin or diuretics? Oxygen is the answer. Because there's nothing that you're going to find on a chest X-ray or on an EKG or on an echocardiogram that's going to say, don't give oxygen to a person who's short of breath. Now they change the question and they say, this history, this physical, and they say, what is the most accurate method of measuring the erection fraction? What's the most accurate? Echo would be, I'm sorry, you said the least accurate? The most accurate is what? Muga. 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 The most accurate is the MUGA. And you go, MUGA, what the hell is that? Oh, the multi-gated scan. Oh, that clears it up. You mean the nuclear ventriculogram? Nuclear ventriculogram? And the answer is yes, that would be the most accurate. The least accurate is the echo. Catheterization and angiography of the left heart is in the middle. They don't ask you that and they say, what would you do first? And the answer is oxygen. The answer is oxygen. The answer is oxygen because the idea here is that here you have this patient, the Dr. Fisher 3-chambered heart. Here is the right atrium. Here is the left ventricle, the right ventricle. And here in the middle, yep, edema does not kill you. It's the blood all being built up here in the middle, in the lungs. In the lungs. That's what kills you. It's all built up here in the lungs. That's what kills you. That's what kills you. You can push the blood out forward with afterload reduction. You could drain the blood out backwards. You could drain the blood out backwards. Drain it out with preload reduction. You could help the squeeze of the heart. Help the ability of the heart to contract. Squeeze the contractility with positive inotropes. You could push the blood out forward with inotropes and help it get out with afterload reduction. You could drain it out backwards with preload reduction. And after oxygen, what would you do first? Afterload reduction, inotropes, or preload reduction? What is first? Preload reduction. What is first in congestive heart failure is preload reduction. A diuretic, nitrates, and what else works at the level of preload reduction? What else? Diuretics, nitrates, and ACE inhibitors doesn't work at preload reduction. Diuretics, nitrates, and morphine. Diuretics, nitrates, and morphine. Diuretics, nitrates, and morphine. The thing that drains the blood out backwards is nitrates, diuretics, and morphine. It is more efficient to drain blood out backwards than to help push it forwards. The most efficient thing is to drain the blood backwards out of the heart. You've given them diuretics, nitrates, and morphine, and 80 to 90% of patients should get better just with preload reduction. But let's say they do this. They give you this patient and say, she has received oxygen, nitrates, morphine, and diuretics, and she's still short of breath. Still short of breath, what would you do now? Emergently, acutely. What can be done acutely to help her breathing? If they've given you diuretics, nitrates, and morphine, and she's still short of breath, what would you do now? You'd use acute management of inotropes. What can you use acutely as an inotropic agent in her? What can you use to increase the contractility of the heart in this person who is acutely short of breath? What will help the squeeze of the heart acutely? What? Digoxin, dopamine, dobutamine. Which of those is a positive inotrope? All of them. The most common wrong answer is digoxin. Digoxin is okay, but not acutely. Acutely, it doesn't work. It takes time for it to build up as an inotrope. Acutely, you'd have to use do, pa, or but. It really looks like dobutamine, doesn't it? What would we use? Dobutamine. Dopa or dobutamine, which of them is a positive inotrope? Both. They're both. Both dopamine and dobutamine are positive inotropes, but which one of them increases the contractility? Both. That's what it means to be a positive inotrope. So, in that case, you will use dobutamine. Dobutamine. Why dobutamine? Why not dopamine? Why not dopamine? What does dobutamine do that dopamine does not do? What does dobutamine do that dopamine does not do? Dobutamine will decrease the afterload as well. Dopamine increases afterload. Dopamine is a pressor. Dopamine constricts those blood vessels and makes it harder for blood to get out of the heart. And the only meaningful ACE inhibitor for afterload reduction, any one of the ACE inhibitors, is fine. Except the person has got a terrible cough. Except the person has a terrible cough with ACE inhibitors, what would you use as an alternative to the ACE inhibitors? That's cute. Angiotensin II receptor blockers. Angiotensin receptor blockers, if you can't tolerate them. Now, which one? Losartan, valsartan, irbesartan, candesartan, or the other sartans? Whatever one you want. And don't learn them by specifics. It's a class effect. It's a class effect. If you can't tolerate ACE inhibitors, you use the angiotensin receptor blockers. When will you use hydralazine and nitrates? When you go into a time machine and you think it's 1984. Then you'll use hydralazine and nitrates. But with the exception of a relativistic speed wormhole time warp going back in time to 1984, you won't answer hydralazine and nitrates. Hydralazine and nitrates is a dog. Hydralazine and nitrates is a dog. So we don't use hydralazine and nitrates. So this is the management of pulmonary edema. Preload reduction first. Sometimes you use positive inotropes like dobutamine acutely. And later on, everybody should get ACE inhibitors. And she gets all better, and she's ready to leave the hospital. And when she's all better, ready to leave the hospital, what do you use when she's ready to leave the hospital, when she's all better? What does she go out on? What does she go home on? What's the long-term management for congestive failure? Everybody should go home on which two drugs? ACE inhibitors and beta blockers. Yes. ACE inhibitors and beta blockers. ACE inhibitors and beta blockers are the two most important things. Diuretics are okay, but what do ACE inhibitors and beta blockers do that digoxin, diuretics, and nitrates and morphine don't do? That's cute. decrease more. It's like a first base coach at baseball, you know. Lowers mortality. What the beta blockers and the ACE inhibitors do that the other drugs don't do is that they lower mortality. And that's why you're going to answer ACE inhibitors and beta blockers. Beta blockers lower mortality more than every other drug here. More even than ACE inhibitors. The greatest decrease in mortality is with beta blockers. 30, 40%. Now what if the ejection fraction is really low though? What if the ejection fraction is like 20%, 18%, 17%? What drug will lower mortality when the ejection fraction is really, really low? The most? Beta blockers. The lower the ejection fraction, the greater the mortality benefit. The lower the ejection fraction, the greater the benefit. You're more likely to live if you take beta blockers, even if your ejection fraction is very low. Look at the idea of this. You've got a weak, half-dead heart, pumping and working and working and working. The digoxin comes along and goes, hey, work more, work more, work more. All right. You'll pump more for a couple of beats, and then you go, I'm not going to deal with this, and have sudden death and die. Now, ACE inhibitors. You're working, you're half dead, and you're working, and you're pushing, and you're pushing. And ACE inhibitors say, no. Don't work so hard. Let me lighten your load. Relax. Don't push so much. Wouldn't you want to live longer? Relax. Don't work so hard. Now, beta blockers lower mortality more than all those. Because beta blockers say, now not only do you have to work less, you have to push less often. You see, for the left ventricle, beta blockers are like a combination of marijuana and Valium. How are you feeling? Hi. You still ischemic? Yeah. How do you feel? It doesn't bother me as much. I'm taking it easy. I don't push as hard. I don't push as frequently. I take a little rest, bigger rest, increasing diastole. I perfuse myself more. It's like going to work in a jacuzzi every day. It's a lot more relaxed and slower. And that's why beta blockers work. The major determinant of myocardial ischemia, is the heart rate. Therefore, the major determinant of decreasing mortality is the beta blocker. The digoxin doesn't decrease heart rate, doesn't decrease mortality. Diuretics don't decrease heart rate, doesn't decrease mortality. ACE inhibitor decreases the amount of work your heart does and decreases the amount of ischemia, and therefore decreases mortality. How do you die of congestive failure? What's the most common method of means of exiting this world when you have congestive failure? How do you die of CHF? It's not this patient. This is not how most people die of CHF. Almost nobody dies like this in this case. Almost nobody drowns to death. Basically, when people die of congestive failure, they die of ischemia-mediated sudden death. Ischemia-mediated sudden death. Beta blockers are anti-ischemic. Beta blockers are antiarrhythmic. Beta blockers lower mortality because people don't die of drowning to death. They die of arrhythmia and ischemia, and that's why they're the best. The most accurate method of assessing ejection fraction is a nuclear ventriculogram, but echoes are always first. The reason I didn't spend much time on issues of EKG and chest X-ray and blood gases is because this person comes in saying, I can't breathe. Of course they're hypoxic. This person comes in and says, I'm breathing very fast. Of course they have a low PCO2. This person comes in and says, I've got Ralls to my apices, JVD, gallop, and murmur. Of course they have congestion on their chest X-ray. If you get an X-ray on this patient and they hand you a normal X-ray, what does it mean? It means they handed you someone else's X-ray. It's not hers. So you don't do anything different. Now, if this is CCS and you can answer everything, you will answer diuretics, nitrates, morphine, chest X-ray, ABG, and EKG, all of this at the exact same time as the oxygen. If this is a CCS and you can order all of them, then you'll order all of them. If you can only answer one thing, you'll say oxygen and diuretic first. You don't do anything different based on the chest x-ray. Do you do anything different based on the blood gas? Is there any difference in action based on the blood gas? No, because you'd give oxygen anyway. No difference in action based on the chest x-ray. Is there any difference in action based on the EKG? Any difference in management based on the EKG? Hello? What if the EKG said SVT? What would you do differently if this patient right in front of you, and the EKG showed supraventricular tachycardia? What would you do differently? Carotid sinus massage, circumferential digital rectal examination, adenosine, calcium blockers, digoxin, or cardioversion. If this patient had supraventricular tachycardia. Cardioversion. Cardioversion. What do you see, Arjuna? I see the eye of the bird, chest pain, shortness of breath, hypotension, confusion. Hemodynamically related confusion. This person, if they had SVT shock, AFib shock, VTAC shock. If this person had VTAC shock, SVT shock, AFib shock, because they're hemodynamically unstable. From the Paleozoic of an hour ago. From the Mesozoic of an hour ago, when we said, what constitutes hemodynamically unstable? This constitutes hemodynamically unstable. So the EKG would change your management. Next case. What happens after you have high blood pressure for 20 years? What happens after 20 years of high blood pressure? What happens to you after 20 years of high blood pressure? End organ damage. Liver? Scrotum. Now to get a rise out of you guys. All right. Which end organ? What's your favorite end organ? You've never told me. Which end organ? 20 years of high blood pressure. Hi, girls. There's a lot of intensity this close, isn't it? Kidney, yeah. 20 years of high blood pressure. Stroke, yeah. 20 years of high blood pressure. Myocardial infarction, yeah. Stroke, MI, CHF, blindness, renal failure. Stroke, MI, CHF, blindness, renal failure. Stroke, MI, blindness, CHF, and renal failure. After 20 years of high blood pressure, that's what end organs you get. You don't get bone problems, you don't get skin problems, you don't get liver problems. You don't get spleen problems. You get stroke, MI, CHF, blindness, and renal. Take 20 years of complications and put it into 20 minutes. And that's hypertensive crisis. 20 years of complications and put it into 20 minutes. 20 years of complications. Stroke, MI, CHF, blindness, renal failure. Stroke. I can't think straight. I'm confused. MI, chest pain. Congestive failure, shortness of breath, blindness, visual disturbance, and blurry vision. Stroke, MI, CHF, blindness, and renal failure. 20 years of complications, put it into 20 minutes, and that's a hypertensive crisis, or urgency, or emergency. Accelerated hypertension, malignant hypertension. What's the difference between malignant hypertension, accelerated hypertension, a hypertensive emergency, urgency, and crisis? Or evil hypertension? What's the difference? They all give end organ damage. Nothing is different. They all mean high blood pressure with end organ damage. They all mean high blood pressure with end organ damage. Now the difference between this and regular hypertension is no repeats, no repeats, no repeats, no lifestyle modifications. Nothing except going straight to therapy. Take 20 years of complications and put it into 20 minutes, and you have a hypertensive crisis. You take 20 years of complications and put it into 20 minutes, 1% of people with high blood pressure, and you go straight to therapy. Now, what's the best initial therapy for somebody with a hypertensive crisis, emergency, urgency, accelerated hypertension, malignant hypertension? What's the best initial therapy for this patient? Nitroprusside or labetalol? Either one. The answer is any intravenous medication is actually okay. Any intravenous medication is okay. Any IV medication is okay in the management of these patients. Anything. Now, there's any IV is okay, but then there's what you actually will use. And the short answer is nitroprusside or labetalol. If you could find IV hydralazine, that's fine, but I don't know if you can even find it. If you could find IV alpha-methyl dopa, which last seen in 1988, then you can use that if you can find it. But when you have labetalol and nitroprusside working for all the patients, you don't need the others. IV enalapril, IV this, IV that. Any intravenous medication could be used, but labetalol and nitroprusside are actually what will be used. They're all okay. Don't use nitroglycerin to lower blood pressure unless there's an MI as well. 20 years of complications and put it into 20 minutes. Stroke, MI, CHF, blindness, and renal failure. Go straight to therapy. No repeats, no repeats, no repeats. Go straight to therapy. When are you going to answer sublingual nifedipine? When will you answer sublingual nifedipine? When you don't like the patient. When you don't like them and you want them to die. And you say, he's suffered enough. Yes, he's suffered enough. And he didn't pay my bill. I think he needs sublingual nifedipine. I'd like to cause a sudden and precipitous drop in blood pressure and try and precipitate a stroke. Because they've suffered enough and I don't like them. Sublingual nifedipine equals death. Just say no to sublingual nifedipine. Sublingual nifedipine is a dog. It's always wrong when you see it. Trimethophan, can't find it. IV hydralazine, can't find it. IV alpha-methyl-dopa, can't find it. IV propranolol, hard to find. Labetalol, nitroprusside, that's fine. Try and stay away from clonidine if you can. Why get rebound? Ruin all those wonderful catecholamines you have so lovingly accumulated in your brain with clonidine when you can have some nice clean nitroprusside or labetalol. Now, this is another version of a congestive failure case. We're only going to be here for a second because we already made the major points about congestive heart failure, which is to use beta blockers and ACE inhibitors. What's the difference between this case and the other cases that we did, the other case we did before, with the lady with the multiple MIs and the pizza with pepperoni in one hand and the kielbasa in her mouth and the bag of Doritos? What's the difference between this case and the others? 1 point of difference. Is that this patient has a history of all of the alcohol use. How do you diagnose for sure that alcohol causes the cardiomyopathy? Now, the management of alcohol-induced cardiomyopathy is the same as the other cardiomyopathies that we said before were dilated cardiomyopathy. It's the same as the others, which is ACE inhibitors, beta blockers. This guy has fluid overload, so diuretics. Digoxin is only used if people still have symptoms, despite the use of those medications. So how do you diagnose for sure that it's alcohol that killed his heart? How do you know for sure it's the alcohol? Blood level. No, you can have a high blood level of alcohol. It doesn't mean you have a cardiomyopathy. The answer is there is no diagnostic test. The answer is there is no diagnostic test. You diagnose congestive heart failure. Does he have a history of MIs? No. Does he have a history of valvular disease? No. You see, to go from a normal heart to a CHF heart, what is the most common reason to go from normal to congestive failure in the United States? What's the most common reason to go from here to here? Hypertension does, but it's not the most common. Hypertension is another way of saying cardiomyopathy. And that's not the most common thing, although cardiomyopathy does. What's the most common reason to go from normal to congestive heart failure? Alcohol, only in my family. But it's not the most common. Ischemia. And MI is the most common reason to go. Valve disease will do it, but it's not the most common. Ischemia, ischemia, ischemia. How do I know that this isn't a guy who has beriberi? How do I know that this isn't Chagas disease? How do I know that this is not really Chagas disease? How do you know for sure that this is not Chagas disease? How do you know for sure that it's not Chagas disease in this history and physical? Because this is not the BMLE, the Brazilian Medical Licensure Exam. If it was the Brazilian Medical Licensure Exam Step 3, then it would be Chagas disease. And the short answer is that you don't know it's not beriberi or radiation or adriamycin. But there's no history of adriamycin. We're not in Brazil. There's no history of radiation. If you take out that he drinks several quarts of adriamycin every day, then it's adriamycin-induced. We rule out the other causes, valve, ischemia, hypertension, and see alcohol in the history, it's alcoholic cardiomyopathy. We rule out the other causes, see adriamycin in the history, it's adriamycin-induced cardiomyopathy. We rule out the other causes, and we see beriberi, adriamycin, cardiomyopathy, radiation, intoxication in the history. The only way to diagnose toxin-induced organ damage is you exclude the most common causes. You exclude the most common causes, and there's the toxin in the history. The toxin in the history. It doesn't change anything. It's still an EKG, a chest X-ray, a blood gas sometimes. And if this is CCS, you will get a chest X-ray and an EKG, and an echo, and do ACE inhibitors, beta blockers, diuretics, and do them all at the same time. If they ask you to choose one single thing first, what would you do as the one single thing first in this guy? What would you do as the one single thing first in this guy? If they ask you to choose one thing first. Oxygen, because he's developed significant shortness of breath. Oxygen first, if he's developed significant short of breath. If you take out this shortness of breath, what would you do first? You're thinking it can't be so simple that it's just the same thing as before. And the answer is, Now, what if we take out the shortness of breath? What would you do first? If you had to choose one single best answer, like 80% of the questions, or one single best answer, what would you do first? I can't hear you. You're speaking in Braille. Stop the alcohol. Oh, a low Budweiser diet. A low Budweiser diet is always good. Okay? The answer would be the diuretic. Because what's his chief complaint? My legs are swollen. His chief complaint is, my legs are swollen. So you have all of these things that you could do. And you're sitting around saying, I'm a psychiatry resident. The answer is consult, consult, consult. And you're like, I don't know what to do first. Okay? Hey, the same way I wouldn't know what to do first if I was answering psychiatry questions, right? I answer 4-point restraints to almost everything. Sometimes 5. Okay? But how do you know which one to pay attention to? The chief complaint tells you. The other lady came in saying, I can't breathe oxygen. I can't breathe oxygen. This guy still says, I can't breathe, so it's oxygen. But if we took out the I can't breathe, then it would be diarismi. Make me pee. First. And then it's the same thing that we said before with the other CHF case. The most accurate diagnostic test is the MUG scan. The best initial way of diagnosis of ejection fraction is the echo. This next case we're going to skip here because it's in your notes, and it's another case of congestive failure, and we will be answering the same thing. So you can read through that case on your own because it is saying the same thing. And we go to case 13, and we find the 17-year-old anorexic nymphette who fainted in ballet class. Hello, I fainted in ballet. I fainted in ballet. And it's called syncope. Now, we have syncope. There are only about 60 separate causes of syncope. Like a half-gallon intellectual enema. You could stretch, but you'd rather not. So the issue is, how do we take 60 separate causes of syncope and reduce it down to something really tiny that you can hold in your hand? You can take all the causes of syncope and reduce it to a few basic questions. The loss of consciousness. The loss of consciousness. Is it sudden or is it gradual? Was I standing around feeling fine and then all of a sudden, bang! Or did I brown out? Did I have a gradual loss of consciousness? Did I feel hot, shaky, sweaty, pale, tachycardic, nauseous, urinating, nauseous, vomiting, the urge to defecate, urinate, hot, shaky, sweaty? Gradual loss of consciousness means what things? What causes gradual loss of consciousness? Not all of a sudden, la 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 la. But, Dios mío, doctor. Gradual is toximetabolic things, toxins and metabolic things. Toximetabolic things. I have a low glucose. I have hypoxia. I have various forms of toxins and drug ingestion and Valium overdose, phenobarbital overdose, opiate overdose. Various forms of toxins and metabolic problems and vasovagal. Gradual loss of consciousness. Toximetabolic and vasovagal. Now, sudden loss of consciousness means two groups of things. What two groups of disorders cause a very sudden loss of consciousness? Is neurologic things like seizures, and cardiac things. Neurologic and cardiac things cause sudden loss of consciousness. I'm fine, I'm perfectly fine, bang, and I'm kissing the floor. Cause sudden loss of consciousness. Now the next thing to do, you say the regaining of consciousness. The regaining of consciousness. Is it sudden? Or is it gradual? Is it sudden or is it gradual? What gives a gradual regaining of consciousness? I'm out, and I wake up and I'm like, yeah, whoa, yeah, hi. What causes a gradual regaining of consciousness? The cardiac or the neurologic? Neurologic. Neurologic loss. Neurologic loss. You don't have a seizure. Hi, how are you? I'm fine. How are you? E equals mc squared. The value of pi to the fifth decimal place equals 3.14. So gradual regaining of consciousness means basically that you seized. A sudden loss of consciousness means that it has to be cardiac. But the thing is that cardiac disease can be arrhythmias and structural heart disease. Arrhythmias and structural heart disease. So the next thing to do is to say, what does the exam show? If the examination of the heart is normal, that means we're talking about a rhythm disturbance. And if the examination of the heart is not normal, if you have some degree of murmur, you have structural heart disease causing it. So we have just taken all forms of syncope and reduced it down to about 3 questions. Is there a sudden loss or gradual loss? Is there sudden regaining or gradual regaining? And what does the exam show? And you say, well, that's really superficial. And my response to that, if you called me superficial and you said Conrad Fisher is superficial, I would say that that's true, basically. But I may be superficial. But I like to think I'm sufficiently satisfying to help you make it through. So yes, it's superficial. And this is not cardiology specialty boards. This is cardiology for poets. Cardiology for people who would like to be doing anesthesia, pathology, psychiatry. And you can get the answers to most of your questions because the main thing that you've got to do when you're looking at syncope, the main issue you have is this, one fundamental issue. Is this cardiac? That's really the fundamental issue with syncope. Why is that basically the fundamental issue? There's a reason for that. There's a reason that says, syncope, make sure it's not cardiac. Why? Because that's the people who die. That's the ones who died. That's the ones who had an MI and had an arrhythmia. That's the ones that have aortic stenosis or IHSS and are going to have sudden death. That's the people who had VTAC and VFib and had sudden cardiac death, and they need an implantable defibrillator to prevent them from having sudden cardiac death. Because the major issue in syncope fundamentally comes down to, is this cardiac? Because that's where the mortality is. That's who dies. Now, with the murmur, there can be basically 3 things. Aortic stenosis, idiopathic hypertrophic subaortic stenosis, also known as hypertrophic obstructive cardiomyopathy, and rarely mitral valve prolapse or most valuable player. And how will you distinguish between these? Between aortic stenosis, hypertrophic obstructive cardiomyopathy, and most valuable player. How will you distinguish between these? Echo is good, and the guy comes and he says, oh, here we go. Here's my echo. Is that what you said? That means hand grip? Is that what that means? Or like this, la 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 la, squat, stand, or lift your legs up in the air, squat, stand, kneel, leg lifts, aerobics classes. Maneuvers. The major issue is maneuvers and location of the murmur. Now, first of all, back to this lady. Let's look at this girl. Let's look at her. 17-year-old anorexic nymphette. Now, the question is, how will you know that she has a sudden loss of consciousness? How will you know? How will you know for sure? Like in this case, how do you know for sure it's sudden? How do you know for sure it's sudden? History of what? How will you know for sure from the history this was sudden? Jogging. No. How do you know for sure in the history it's sudden? Witness. No. How do you know for sure this is sudden? How am I? We gotta know. Because it says she suddenly passed out. Suddenly passed out. And she passed out for less than a minute, and feels fine afterwards. Ding, 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 ding. And we know it's cardiac. Sudden loss, sudden regaining. Because they tell you, hey, do you know that there's an advantage to a board test? I know you don't think there's an advantage to a board test, but there is. The advantage is that if they want you to know the answer, they have to tell you something. They can't go, hi, I'm here. I have no symptoms. What do I have? No, that's not it. No, that's not it. Kluver-Bucy? No. Tourette's? Closer. You can't say it. If they want you to know the answer, they have to tell you something. They have to tell you. For instance, lots of people can pass out, and I'll tell you, 40 to 60% of the time, minimum, you never find out. Half the time, you never find out. Actually, up to 80% of the time, you do not find the etiology of the syncope. 80% of the time. The average inpatient hospital unit with the average age of the patient is 172. There's a little old lady admitted for syncope. How do you know she passed out? Well, normally she lies on this side, and we found her lying on that side. And you never find out. So if they want you to know the answer, they have to tell you. Suddenly lost consciousness, they tell you she's suddenly lost consciousness. They tell you she feels fine right away. Now, automatically, that largely tells us that it's a 17-year-old person that's unlikely to be aortic stenosis. But how do we know that this patient does not have aortic stenosis? For instance, she could have a congenital bicuspid aortic valve. How do you know this isn't a congenital bicuspid aortic valve? The murmur is wrong. The murmur of aortic stenosis should be in which area? Mitral, tricuspid, pulmonic, or aortic? The aortic area? That's right. APTM. APTM. Aortic, pulmonic, tricuspid, and mitral. Aortic, pulmonic, tricuspid, and mitral. APTM. Apartment M. Apartment M. It would be at the aortic area, the aortic stenosis. That's a good place for the aortic murmurs to be. I think we'll call it the aortic area. How else can you tell that this patient does not have aortic stenosis? The maneuvers are the opposite. The maneuvers are the opposite. The maneuvers are the opposite. Aortic stenosis, more blood means more murmur. More blood means more murmur. Worsens with Valsalva. What is the hemodynamic effect upon the heart of the Valsalva? What's the hemodynamic effect upon the heart of the Valsalva maneuver? More blood or less blood? Less blood. Less blood. Please exhale against the closed glottis. What? Can you make like you're having a bowel movement? Excuse me? Oh, you know. Decreases venous return to the heart. Decreases venous return to the heart. Less blood. Less blood, less murmur. What is the hemodynamic effect upon the heart of going from standing to squatting? More blood or less blood? More blood. You're squeezing up on the leg veins like squeezing up on the bottom of a tube of toothpaste. More blood. Aortic stenosis. More blood, more murmur, less blood, less murmur. Aortic stenosis would do the opposite, but not just aortic stenosis. Aortic stenosis would do the same thing. Mitral stenosis, mitral regurg, aortic regurg, all of them. More blood, more murmur. The only two in which you have more blood resulting in improvement, that it's better, is IHSS and mitral valve prolapse. Hypertrophic obstructive cardiomyopathy and mitral valve prolapse. More blood and it's better, like this person. What's the most common presentation of IHSS? What's the most common presentation? Sudden death. Ooh, that'd be hard to make a specialty. What's your specialty? IHSS. What are your patients here with? Death. They keep coming in being dead. What do you do all day long? Go to funerals. Hard to make a specialty out of that. The most common wrong answer is sudden death. The most common presentation is shortness of breath. Sorry, IHSS. I'd like for it to be dramatic and sexy and dribble, 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 shoot, score, die. That's just the one that gets you on CNN. No one likes to say, 27-year-old basketball player. Hi, reporting from Houston Astrodome. What are they playing that? Is that the one, the little orange one that goes through the net, or the white one that you hit with the stick? Well, anyway, I'm reporting from Meadowlands Arena. A patient ran across the court today and fell short of breath. Not too dramatic. You don't hear about that. But that's the most common presentation. The most common presentation you hear about is sudden death. It happens to be the least common presentation. The most common is simple shortness of breath. How do you know that she doesn't have mitral valve prolapse? What's wrong about the presentation? If this was mitral valve prolapse, what would be the most common chief complaint? Palpitations? Panic with prolapse? Mitral valve prolapse gives palpitations? Pain with prolapse, palpitations, and panic disorder, prolapse. That's correct. That's how you know this is IHSS. So the issue also is they both have the same best initial therapy. IHSS and hypertrophic cardiomyopathy both have the same best initial therapy, which is beta blockers, beta blockers, beta blockers. Because beta blockers allow for more filling, more diastolic filling time, and since more blood, it gets better. It fills more, and it's better. Beta blockers, both of them. Here, hypertrophic obstructive cardiomyopathy, shortness of breath, syncope, rarely sudden death. That's her. Mitral valve prolapses, pain, palpitations, and panic disorders, but still beta blockers. Next case. How do you know that the 36-year-old Ecuadorian, how do you know that she's not short of breath from tuberculosis? Young, short of breath, coughing up blood at you. How do you know that this is not tuberculosis? Well, you know for sure it can't be tuberculosis because we are in the cardiology section. But how else do you know that this is not tuberculosis from the history and physical? Well, for one thing, she's not febrile. Another thing is, any weight loss? No, no fever, no weight loss. How else do you know that this is not tuberculosis? Because she's got a big screaming opening snap. She's got a big screaming opening snap. That's how you know that this is not mitral stenosis. Because she's got a big screaming opening snap. And that's how you know it's not TB. TB does not give you a big, screaming, opening snap. What would be the best initial therapy for this woman for mitral stenosis? Does digoxin help mitral stenosis? Does digoxin help? No. No. First of all, with mitral stenosis, you're going to look for the person who is pregnant in the history. Why look for the pregnant woman? Why look for the pregnant woman? Increased plasma volume. Because the pregnant woman has an increased plasma volume. The increased plasma volume in the pregnant woman So you're going to look for the increased plasma volume, and therefore they become symptomatic during pregnancy because the plasma volume goes up by 50%, but the size of the orifice does not. What else is more in the history with mitral stenosis compared to any other valvular disease? What's different about mitral stenosis? It's the one that gives the most amount of AFib and therefore the most amount of strokes. It's the only one that gives dysphagia, the only one that gives you hoarseness because of pressing on the recurrent laryngeal nerve. The best initial therapy for her is diuretics because you want to pull off blood that is behind that stenotic mitral valve. If this is the left atrium and you have the stenotic mitral valve, digoxin helps with ventricular emptying. But we don't have a problem with ventricular emptying. We have a problem with ventricular filling. ACE inhibitors work on ventricular emptying, but we don't have a problem with ventricular emptying. We have a problem with ventricular filling. So diuretics will help drain out that left atrium. So she gets put on a diuretic. You restrict her salt, she gets more short of breath. You give her more diuretic, she becomes more short of breath. She progresses through diuretics, she progresses through salt restriction. Digoxin won't work, and ACE inhibitors won't work. So what's the next best step in therapy for someone who has mitral stenosis not controlled by diuretics? Commissurotomy valve replacement balloon. Balloon. Universal balloon sign. That's good. If you had to have mitral stenosis, what would you like about a balloon that's better than valve replacement? The thing about balloon that's better than valve replacement is that there's no way to do that valve replacement without going through your heart, without going through your chest. The valve replacement, I have to crack open your chest, open up your heart, rip out your valve, put in a piece of bacon, a pork valve, porcine valve, which lasts for 10 years, and then you got to replace it every 10 years. Or a piece of metal valve, which has to have lifelong Coumadin. And you say, no problem, you just can't get pregnant, or you have to be on heparin for the entire 9 months of your pregnancy. So when you have mitral stenosis not getting better with preload reduction, it is always balloon, balloon, balloon. You put a balloon in there and pop, and it opens it up, and all of a sudden you have a nice floppy open mitral valve. Sure, 5 or 10% of the time you get mitral regurgitation, but you didn't have to have your sternum cracked open. You only do a valve replacement if you balloon and it doesn't get better with medications, then you replace the valve. Mitral stenosis, number one presentation, shortness of breath. But any form of valve disease can give you shortness of breath. The one that's characteristic to mitral stenosis, besides the opening snap, is most in the pregnant woman, most amount of AFib, because the atrium is the biggest, most amount of strokes, because the atrium is the biggest, most amount of emboli, because the atrium is the biggest, most amount of thrombi, because the atrium is the biggest, most amount of dysphagia, because the atrium gets big and presses on the esophagus. And you balloon it, and you're done. All valve disease has the same answer. Echo, cath. Echocardiogram, catheterization. Echocardiogram and catheterization. All valve disease has the same basic answer. Echocardiogram and a cardiac catheterization in terms of therapy. For these last two cases, they're relatively much less complex than the other cases in cardiology. Ischemic heart disease, valvular heart disease, arrhythmias are rather large and involved. These next two cases basically have 2 or 3 points to be made per case because the number of things that can be asked is relatively limited. A guy who comes in and says, I have cramping pain in my calf while walking, virtually says, my chief complaint is I have peripheral vascular disease. So it's exquisitely unlikely that they're going to ask you the diagnosis. What is it? Well, Tsutsugamushi fever? Australian scrub typhus? What else can it be? First he says, I've got vascular disease, and then he says again, I have intermittent claudication. And that's pain in his calves that goes away when he rests. So his chief complaint is, I have peripheral vascular disease. The questions here are going to be relatively simple, such as, which of the following would be the most accurate diagnostic test? Well, any vascular disease that they say the most accurate diagnostic test, the most accurate test for any vascular disease is always the angiogram. Is always the angiogram. The most accurate diagnostic test for any vascular disease is always angiography. So it's unlikely that they'll ask you that. What needs to be changed in terms of his medications? What needs to be changed in terms of his meds? Needs to get rid of that beta blocker. Because beta blockers can contribute to worsening of peripheral vascular disease. Beta stimulation dilates. Beta blockade might constrict. Beta stimulation dilates. Beta blockade, therefore, might constrict. He's got to knock off that smoking. What is the most effective therapy for this patient? No, bypass. The most effective thing to getting over your obstructed vascular lesion is to bypass that vascular lesion. The most accurate test for any vascular lesion is always angiography. To bypass vascular lesions. Can't do it in the brain, but you can do it in the heart. You can do it in the peripherals. To bypass. Surgery. Renal artery stenosis? Surgically resect. Peripheral vascular disease, surgically resect. Coronary vascular disease, surgically resect it as most effective therapy. Not first, not initial, but most effective. Question. Will calcium blockers help, yes or no? Will calcium blockers help, yes or no? No. The most common wrong answer for peripheral vascular disease is answering calcium blockers. Because there's a fundamental misunderstanding about vascular disease. It's not a vasospastic problem. It is an atheromatous, fibrofatty, lipid-laden booger on the inside of my vasculature. Not vasospasm. Raynaud's, calcium blockers. Pulmonary hypertension, calcium blockers. Subarachnoid hemorrhage, calcium blockers. When you have vasospasm, then it's calcium blockers. This is not vasospasm. It's not Raynaud's. It's atheromatous plaque. Therefore, I need to stop smoking and start aspirin. Get rid of my beta blockers because beta stimulation dilates. Beta stimulation dilates. So beta blockade must constrict. Don't answer calcium blockers. Something's got to be the wrong answer. Silastazole. Oh no. It's like tyrofiban eptifibatide. Abscissumab, another new drug that I've never heard of. Oh no. Silastazole. What the hell is that? Well, listen, you got peripheral vascular disease. If you had peripheral vascular disease, what would you want your drug to do? Cause erection. But besides that, because it is basically a vascular phenomenon, you'd want a drug that was antiplatelet and vasodilating. An antiplatelet vasodilator. And silastazole is an antiplatelet vasodilator. It stops the clogging up of your arteries by inhibiting platelets, and it dilates your arteries by being vasodilatory. Aspirin, stop the smoking. Calcium blockers, no. Silastazole, yes. Most effective, bypass. Most accurate test, angiography. Peripheral vascular disease. Next case. Finalmente. I have a painful leg and a swollen ankle. A painful leg and a swollen ankle. I've got a history of breast cancer. I've got edema at my ankle. And I've got Hohmann's sign, the world's most nonspecific finding. Half the people with a DVT have it, and half the people who have it, the sign, don't have a DVT. The world's most nonspecific finding. Hohmann's sign. Half the people who have Hohmann's, need to go out running more. Half the people who have a DVT don't have the finding. What would be the most accurate diagnostic test for this patient? Doppler is a very good test to do initially, but it's not as accurate as a venogram. So venography is the most accurate. So you do venography in everybody. Didn't you just say that you do venography? Didn't you just say that? No, I said most accurate. I didn't say what I do. The most accurate thing is venography. But I didn't say I do venography. I just said it's the most accurate. The most accurate is venography, but don't do venography. It's got contrast. No one ever got renal failure from a duplex ultrasonogram. No one ever had anaphylaxis from sound. No one ever had anaphylaxis from duplex ultrasonogram. No one ever had renal failure from a duplex ultrasonogram. But the most accurate is venography. It depends what they ask you. What do they ask you? What do they ask you? Which is more effective, IV heparin or sub-Q heparin in this patient? IV or sub-Q? IV or sub-Q? Equal. They are exactly equal. Whether you use IV unfractionated heparin or low molecular weight subcutaneous heparin, 10 years from now, 20 years from now, when your children are in medical school, your kid's going to say, Dad, is it true that you guys used to hospitalize patients for a DVT? Wow, that's so quaint. 30 years ago, they used to hospitalize you for a barium enema. Admit you for a barium enema. Admit you for a stress test. And you'd go now, you go like, are you kidding me? Admit you for a stress test or a barium enema? Hey, listen, the first colonoscopy in the United States is only 32 years ago. Used to admit you for that. Now, you do it on the drive-thru between McDonald's. You eat here, you scope here, and you're done. Okay, it's like my new series of all-you-can-eat pasta restaurants combined with simultaneous liposuction. You get it? So the same way, here, you won't even get admitted for a DVT. Here's your prescription for Lovenox, dalteparin, enoxaparin, low molecular weight heparin. Go! And you're done for a DVT. IV and low molecular weight heparin are equal. How long do you have to continue the Coumadin for? 6 months at most. But that's not what they'll ask you. They'll say, when do you start the Coumadin? As soon as you start the heparin. Right away, so that you can get therapeutic on your Coumadin while waiting for your heparin to go off in 5 days. You don't want to start your Coumadin when you're ready to stop the heparin. You start the heparin and the Coumadin at the same time, simply so that 5 days later, you have a therapeutic Coumadin level, a therapeutic INR, forget about PT, a therapeutic INR, international normalized ratio, at 2 to 3. And by the way, 2 to 3 is your answer for everything except metallic heart valves. Your answer for Coumadin is everything. INRs of 2 to 3 except for metallic heart valves, which is 3 to 4. DVT, 2 to 3. Pulmonary embolus, 2 to 3. INR of 2 to 3. Porcine valve? No, nothing. You don't have to give anticoagulation for porcine valves. Piggy. No Coumadin for piggy valves. No Coumadin for pork. For bacon valves. Most accurate, venogram. But don't do a venogram. But if they say most accurate, it is the venogram. Okay. You look, best initial would be duplex ultrasonogram. You look at each disease. And you say, from each disease, there's only a limited number of things that you can be asked. You walk in on test day with a pocket full of answers. And you say, okay, DVT, well, let's see, where's my best initial test? Oh yeah, there it is. Where's my most accurate test? Oh yeah, there it is. Venogram. My best initial therapy. Coumadin and heparin. Oh yeah, there it is. My most effective therapy. Coumadin and heparin. You walk in with a pocket full of answers for each one because there's a limited number of things they can ask you about each disease. Now this is for all the diseases. The same way, you're playing chess. You're playing chess. And there's a limited number of moves. Let's say that you have a knight. You have a little horsey, right? I'm trying to do a horsey now, okay? Don't get upset if it looks more like a knight. It looks more like a... This is a 4-week embryo. And you say, oh, well, the knight can only have a certain number of moves. The knight can only move a certain number of places. The knight cannot move from here to here. They can't say, which of the following is the second best test? The knight can't move from here to here. You say from this position, you can move that knight over to here, right, to here. The same way, you have a particular disease called a DVT. You only have a certain number of things that can be asked about that disease. You walk in saying, these are the answers for all the questions I can get. The same way that you can't have a bishop that's going to decide to move horizontally. There's only a limited number of moves for each piece. There's only a limited number of questions for each disease. The idea is to study each disease so that you walk in on test day not going, gee, what is the most accurate test for a pulmonary embolism, a myocardial infarction, cellulitis, endocarditis, lung cancer? What is the most accurate? No, you walk in pre-digested for those questions. The same way you know that the knight can only move to a certain number of spaces. Namaste. Bye.